Male circumcision is the removal of the foreskin from the human penis. In the most common procedure, the foreskin is opened, adhesions are removed, and the foreskin is separated from the glands. After that, a circumcision device may be placed and then the foreskin is cut off. Topical or locally injected anesthesia is used to reduce pain and physiologic stress. For adults and children, general anesthesia is an option and the procedure may be performed without a specialized circumcision device. The procedure is most often an elective surgery performed on babies and children for religious or cultural reasons. In other cases it may be done as a treatment for certain medical conditions or for preventative reasons. Medically it is a treatment option for problematic cases of phimosis, balanoposthitis that does not resolve with other treatments, and chronic urinary tract infections, UTIs. It is contraindicated in cases of certain genital structure abnormalities or poor general health. The positions of the world's major medical organizations range from considering elective circumcision of babies and children as having no benefit and significant risks to having a modest health benefit that outweighs small risks. No major medical organization recommends either universal circumcision of all males or banning the procedure. Ethical and legal questions regarding informed consent and human rights have been raised over the circumcision of babies and children for non-medical reasons. For these reasons the procedure is controversial. Male circumcision reduces the risk of HIV infection among heterosexual men in sub-Saharan Africa. Therefore, the WHO recommends considering circumcision as part of a comprehensive HIV prevention program in areas with high rates of HIV such as sub-Saharan Africa. Evidence for a health benefit against HIV for men who have sex with men is also strong. Likewise, the effectiveness of using circumcision to prevent HIV in the developed world is also unclear. Circumcision is associated with reduced rates of cancer-causing forms of human papillomavirus, HPV, UTIs, and cancer of the penis. Prevention of those conditions is not a justification for routine circumcision of infants. Studies of other sexually transmitted infections are suggestive that circumcision is protective. A 2010 review found circumcisions performed by medical providers to have a typical complication rate of 1.5% for babies and 6% for older children, with few cases of severe complications. Bleeding, infection, and the removal of either too much or too little foreskin are the most common complications cited. Complication rates are higher when the procedure is performed by an inexperienced operator, in unsterile conditions, or in older children. Circumcision does not appear to have a negative impact on sexual function. An estimated 1/3 of males worldwide are circumcised. The procedure is most common among Muslims and Jews, where it is near universal for religious reasons, in the United States and parts of Southeast Asia and Africa. It is relatively rare in Europe, Latin America, parts of southern Africa, and most of Asia. The origin of circumcision is not known with certainty. The oldest documented evidence for it comes from ancient Egypt. Various theories have been proposed as to its origin, including as a religious sacrifice and as a rite of passage marking a boy's entrance into adulthood. It is part of religious law in Judaism and is an established practice in Islam, Coptic Christianity, and the Ethiopian Orthodox Church. The word circumcision is from Latin circumcidere, meaning to cut around. Uses: elective. Neonatal circumcision is usually elected by the parents for non-medical reasons, such as religious beliefs or personal preferences, possibly driven by societal norms. Outside the parts of Africa with high prevalence of HIV/AIDS, the positions of the world's major medical organizations on non-therapeutic neonatal circumcision range from considering it as having a modest net health benefit that outweighs small risks to viewing it as having no benefit with significant risks for harm. No major medical organization recommends universal neonatal circumcision, and no major medical organization calls for banning it either. The Royal Dutch Medical Association, which expresses some of the strongest opposition to routine neonatal circumcision, does not call for the practice to be made illegal out of their concern that parents who insist on the procedure would turn to poorly trained practitioners instead of medical professionals. This argument to keep the procedure within the purview of medical professionals is found across all major medical organizations. In addition, the organizations advise medical professionals to yield to some degree to parental preferences, which are commonly based upon cultural or religious views, in their decision to agree to circumcise. The Danish College of General Practitioners states that circumcision should only when medically needed, otherwise it is a case of mutilation. Medical circumcision may be used to treat pathological phimosis, refractory balanoposthitis and chronic or recurrent urinary tract infections, UTIs. The World Health Organization promotes circumcision to prevent female-to-male HIV transmission in countries with high rates of HIV. The International AIDS Society USA also suggests circumcision be discussed with MSM who engage in primarily insertive anal sex, especially in areas where HIV is common. The finding that circumcision significantly reduces female-to-male HIV transmission has prompted medical organizations serving communities affected by endemic HIV/AIDS to promote circumcision as an additional method of controlling the spread of HIV. The World Health Organization, WHO, and UNAIDS, 2007, recommend circumcision as part of a comprehensive program for prevention of HIV transmission in areas with high endemic rates of HIV, as long as the program includes informed consent, confidentiality, and absence of coercion. Contraindications. Circumcision is contraindicated in infants with certain genital structure abnormalities, such as a misplaced urethral opening, as in hypospadias and epispadias, curvature of the head of the penis, chordee, or ambiguous genitalia, because the foreskin may be needed for reconstructive surgery. Circumcision is contraindicated in premature infants and those who are not clinically stable and in good health. If an individual, child or adult, is known to have or has a family history of serious bleeding disorders, hemophilia, it is recommended that the blood be checked for normal coagulation properties before the procedure is attempted. Technique. The foreskin extends out from the base of the glans and covers the glans when the penis is flaccid. Proposed theories for the purpose of the foreskin are that it serves to protect the penis as the fetus develops in the mother's womb, that it helps to preserve moisture in the glans, and that it improves sexual pleasure. The foreskin may also be a pathway of infection for certain diseases. Circumcision removes the foreskin at its attachment to the base of the glans. Removal of the foreskin. For infant circumcision, devices such as the Gumco clamp, Plastibell and Mogan clamp are commonly used in the USA. These follow the same basic procedure. First, the amount of foreskin to be removed is estimated. The practitioner opens the foreskin via the preputial orifice to reveal the glans underneath and ensures it is normal before bluntly separating the inner lining of the foreskin, preputial epithelium, from its attachment to the glans. The practitioner then places the circumcision device. This sometimes requires a dorsal slit, which remains until blood flow has stopped. Finally, the foreskin is amputated. For older babies and adults, circumcision is often performed surgically without specialized instruments, and alternatives such Unicirc, Prepex, or the Shang ring are available. Pain management. The circumcision procedure causes pain, and for neonates this pain may interfere with mother-infant interaction or cause other behavioral changes, so the use of analgesia is advocated. Ordinary procedural pain may be managed in pharmacological and non-pharmacological ways. Pharmacological methods, such as localized or regional pain-blocking injections and topical analgesic creams, are safe and effective. The ring block and dorsal penile nerve block, DPNB, are the most effective at reducing pain, and the ring block may be more effective than the DPNB. They are more effective than EMLA, eutectic mixture of local anesthetics, cream, which is more effective than a placebo. Topical creams have been found to irritate the skin of low birth weight infants, so penile nerve block techniques are recommended in this group. For infants, non-pharmacological methods such as the use of a comfortable, padded chair and a sucrose or non-sucrose pacifier are more effective at reducing pain than a placebo, but the American Academy of Pediatrics, AAP, states that such methods are insufficient alone and should be used to supplement more effective techniques. A quicker procedure reduces duration of pain. Use of the Mogan clamp was found to result in a shorter procedure time and less pain-induced stress than the use of the Gumco clamp or the Plastibell. The available evidence does not indicate that post-procedure pain management is needed. For adults, topical anesthesia, ring block, dorsal penile nerve block, DPNB, and general anesthesia are all options, and the procedure requires 4 to 6 weeks of abstinence from masturbation or intercourse to allow the wound to heal. Effects: sexually transmitted diseases. Human immunodeficiency virus. There is strong evidence that circumcision reduces the risk of men acquiring HIV infection in areas of the world with high rates of HIV. Evidence among heterosexual men in sub-Saharan Africa shows an absolute decrease in risk of 1.8%, which is a relative decrease of between 38% and 66% over 2 years, and in this population studies rate it cost-effective. Whether it is of benefit in developed countries is undetermined. There are plausible explanations based on human biology for how circumcision can decrease the likelihood of female-to-male HIV transmission. The superficial skin layers of the penis contain Langerhans cells, which are targeted by HIV. Removing the foreskin reduces the number of these cells. When an uncircumcised penis is erect during intercourse, any small tears on the inner surface of the foreskin come into direct contact with the vaginal walls, providing a pathway for transmission. When an uncircumcised penis is flaccid, the pocket between the inside of the foreskin and the head of the penis provides an environment conducive to pathogen survival. Circumcision eliminates this pocket. Some experimental evidence has been provided to support these theories. The WHO and the Joint United Nations Programme on HIV/AIDS, UNAIDS, state that male circumcision is an efficacious intervention for HIV prevention, but should be carried out by well-trained medical professionals and under conditions of informed consent, parents' consent for their infant boys. The WHO has judged circumcision to be a cost-effective public health intervention against the spread of HIV in Africa, although not necessarily more cost-effective than condoms. The joint WHO/UNAIDS recommendation also notes that circumcision only provides partial protection from HIV and should not replace known methods of HIV prevention. Male circumcision provides only indirect HIV protection for heterosexual women. It is unknown whether or not circumcision reduces transmission when men engage in anal sex with a female partner. Some evidence supports its effectiveness at reducing HIV risk in men who have sex with men. Human papillomavirus. Human papillomavirus, HPV, is the most commonly transmitted sexually transmitted infection, affecting both men and women. While most infections are asymptomatic and are cleared by the immune system, some types of the virus cause genital warts, and other types, if untreated, cause various forms of cancer, including cervical cancer, and penile cancer. Genital warts and cervical cancer are the two most common problems resulting from HPV. Circumcision is associated with a reduced prevalence of oncogenic types of HPV infection, meaning that a randomly selected circumcised man is less likely to be found infected with cancer-causing types of HPV than an uncircumcised man. It also decreases the likelihood of multiple infections. No strong evidence indicates that it reduces the rate of new HPV infection, but the procedure is associated with increased clearance of the virus by the body, which can account for the finding of reduced prevalence. Although genital warts are caused by a type of HPV, there is no statistically significant relationship between being circumcised and the presence of genital warts. Other infections. Studies evaluating the effect of circumcision on the rates of other sexually transmitted infections have generally found it to be protective. A 2006 meta-analysis found that circumcision was associated with lower rates of syphilis, chancroid, and possibly genital herpes. A 2010 review found that circumcision reduced the incidence of HSV-2, herpes simplex virus, type 2, infections by 28%. The researchers found mixed results for protection against Trichomonas vaginalis and Chlamydia trachomatis and no evidence of protection against gonorrhea or syphilis. It may also possibly protect against syphilis in men who have sex with men. Phimosis, balanitis, and balanoposthitis. Phimosis is the inability to retract the foreskin over the glans penis. At birth, the foreskin cannot be retracted due to adhesions between the foreskin and glans, and this is considered normal, physiological phimosis. Over time the foreskin naturally separates from the glans, and a majority of boys are able to retract the foreskin by age 3. Less than 1% are still having problems at age 18. If the inability to do so becomes problematic, pathological phimosis, circumcision is a treatment option. This pathological phimosis may be due to scarring from the skin disease balanitis xerotica obliterans, BXO, repeated episodes of balanoposthitis or forced retraction of the foreskin. Steroid creams are also a reasonable option and may prevent the need for surgery, including in those with mild BXO. The procedure may also be used to prevent the development of phimosis. Phimosis is also a complication that can result from circumcision. An inflammation of the glans penis and foreskin is called balanoposthitis, and the condition affecting the glans alone is called balanitis. Most cases of these conditions occur in uncircumcised males, affecting 4–11% of that group. The moist, warm space underneath the foreskin is thought to facilitate the growth of pathogens, particularly when hygiene is poor. Yeasts, especially Candida albicans, are the most common penile infection and are rarely identified in samples taken from circumcised males. Both conditions are usually treated with topical antibiotics, metronidazole cream, and antifungals, clotrimazole cream, or low-potency steroid creams. Circumcision is a treatment option for refractory or recurrent balanoposthitis, but in recent years the availability of the other treatments have made it less necessary. Urinary tract infections. A UTI affects parts of the urinary system including the urethra, bladder, and kidneys. There is about a 1% risk of UTIs in boys under 2 years of age, and the majority of incidents occur in the first year of life. There is good but not ideal evidence that circumcision of babies reduces the incidence of UTIs in boys under 2 years of age, and there is fair evidence that the reduction in incidence is by a factor of 3–10 times. 100 circumcisions prevents 1 UTI. Prevention of UTIs does not justify routine use of the procedure, however. Circumcision is most likely to benefit boys who have a high risk of UTIs due to anatomical defects, and may be used to treat recurrent UTIs. There is a plausible biological explanation for the reduction in UTI risk after circumcision. The orifice through which urine passes at the tip of the penis, the urinary meatus, hosts more urinary system disease-causing bacteria in uncircumcised boys than in circumcised boys, especially in those under 6 months of age. As these bacteria are a risk factor for UTIs, circumcision may reduce the risk of UTIs through a decrease in the bacteria population. Cancers. Circumcision has a protective effect against the risks of penile cancer in men, and cervical cancer in the female sexual partners of heterosexual men. Penile cancer is rare, with about 1 new case per 100,000 people per year in developed countries and higher incidence rates per 100,000 in sub-Saharan Africa. For example, 1.6 in Zimbabwe, 2.7 in Uganda and 3.2 in Swaziland. The number of new cases is also high in certain South American countries such as Paraguay and Uruguay at about 4.3 per 100,000. It is least common in Israeli Jews, 0.1 per 100,000, related in part to the very high rate of circumcision of babies. Penile cancer development can be detected in the carcinoma in situ, CIS, cancerous precursor stage and at the more advanced invasive squamous cell carcinoma stage. Childhood or adolescent circumcision is associated with a reduced risk of invasive squamous cell carcinoma in particular. There is an association between adult circumcision and an increased risk of invasive penile cancer. This is believed to be from men being circumcised as a treatment for penile cancer or a condition that is a precursor to cancer rather than a consequence of circumcision itself. Penile cancer has been observed to be nearly eliminated in populations of males circumcised neonatally. Important risk factors for penile cancer include phimosis and HPV infection, both of which are mitigated by circumcision. The mitigating effect circumcision has on the risk factor introduced by the possibility of phimosis is secondary, in that the removal of the foreskin eliminates the possibility of phimosis. This can be inferred from study results that show uncircumcised men with no history of phimosis are equally likely to have penile cancer as circumcised men. Circumcision is also associated with a reduced prevalence of cancer-causing types of HPV in men and a reduced risk of cervical cancer, which is caused by a type of HPV, in female partners of men. As penile cancer is rare, and may become increasingly rare as HPV vaccination rates rise, and circumcision has risks, the practice is not considered to be valuable solely as a prophylactic measure against penile cancer in the United States. There is some evidence that circumcision is associated with lower risk of prostate cancer. A 2015 meta-analysis found a reduced risk of prostate cancer associated with circumcision in black men. A 2016 meta-analysis found that men with prostate cancer were less likely to be circumcised. Women's health. A 2017 systematic review found consistent evidence that circumcision was associated with a decreased risk of cervical cancer, cervical dysplasia, HSV2, chlamydia, and syphilis among women. The evidence was less consistent in regards to the potential association of circumcision with women's risk of HPV and HIV. Adverse effects. Neonatal circumcision is generally safe when done by an experienced practitioner. The most common acute complications are bleeding, infection, and the removal of either too much or too little foreskin. These complications occur in approximately 0.12% of procedures, and constitute the vast majority of all acute circumcision complications in the United States. Minor complications are reported to occur in 3% of procedures. Severe complications are rare. A specific complication rate is difficult to determine due to scant data on complications and inconsistencies in their classification. Complication rates are greater when the procedure is performed by an inexperienced operator, in unsterile conditions, or when the child is at an older age. Significant acute complications happen rarely, occurring in about 1 in 500 newborn procedures in the United States. Severe to catastrophic complications, including death, are so rare that they are reported only as individual case reports. Other possible complications include buried penis, chordee, phimosis, skin bridges, urethral fistulas, and meatal stenosis. These complications may be avoided with proper technique, and are most often treatable without requiring a hospital visit. Pain. The circumcision procedure may carry the risks of heightened pain response for newborns and dissatisfaction with the result. Newborns that experience pain due to being circumcised have different responses to vaccines given afterwards, with higher pain scores observed. Sexual effects. The highest quality evidence indicates that circumcision does not decrease the sensitivity of the penis, harm sexual function or reduce sexual satisfaction. A 2013 systematic review found that circumcision did not appear to adversely affect sexual desire, pain with intercourse, premature ejaculation, time until ejaculation, erectile dysfunction, or difficulties with orgasm. However, the study found that the existing evidence is not very good. Another 2013 systematic review found that the highest quality studies reported no adverse effects of circumcision on sexual function, sensitivity, sensation, or satisfaction. A 2017 systematic review and meta-analysis found that circumcision did not affect premature ejaculation. Psychological effects. Behavioral effects have been observed following infant circumcision, including changes in sleep patterns, irritability, changes in feeding, and parental bonding. Some men who were circumcised as an infant involuntarily described their feelings about the procedure using the terms violation, torture, mutilation, and sexual assault. Prevalence. Circumcision is one of the world's most widely performed procedures. Approximately 37% to 39% of males worldwide are circumcised, about half for religious or cultural reasons. It is most often practiced between infancy and the early 20s. The WHO estimated in 2007 that 664,500,000 males aged 15 and over were circumcised, 33% global prevalence, almost 70% of whom were Muslim. Circumcision is most common in the Muslim world, Israel, South Korea, the United States and parts of Southeast Asia and Africa. It is relatively rare in Europe, Latin America, parts of Southern Africa and Oceania and most of Asia. Prevalence is near universal in the Middle East and Central Asia. Non-religious circumcision in Asia, outside of the Republic of Korea and the Philippines, is fairly rare, and prevalence is generally low, less than 20%, across Europe. Estimates for individual countries include Taiwan at 9% and Australia 58.7%. Prevalence in the United States and Canada is estimated at 75% and 30% respectively. Prevalence in Africa varies from less than 20% in some southern African countries to near universal in North and West Africa. The rates of routine neonatal circumcision over time have varied significantly by country. In the United States, hospital discharge surveys estimated rates at 64.7% in the year 1980, 59.0% in the year 1990, 62.4% in the year 2000, and 58.3% in the year 2010. These estimates are lower than the overall circumcision rates, as they do not account for non-hospital circumcisions, or for procedures performed for medical or cosmetic reasons later in life. Community surveys have reported higher neonatal circumcision. Canada has seen a slow decline since the early 1970s, possibly influenced by statements from the AAP and the Canadian Pediatric Society issued in the 1970s saying that the procedure was not medically indicated. In Australia, the rate declined in the 1970s and 80s, but has been increasing slowly as of 2004. In the United Kingdom, rates are likely to have been 20–30% in the 1940s but declined in the late 40s. One possible reason may have been a 1949 British Medical Journal article which stated that there was no medical reason for the general circumcision of babies. The overall prevalence of circumcision in South Korea has increased markedly in the second half of the 20th century, rising from near zero around 1950 to about 60% in 2000, with the most significant jumps in the last 2 decades of that time period. This is probably due to the influence of the United States, which established a trusteeship for the country following World War II. Medical organizations can affect the neonatal circumcision rate of a country by influencing whether the costs of the procedure are borne by the parents or are covered by insurance or a national health care system. Policies that require the costs to be paid by the parents yield lower neonatal circumcision rates. The decline in the rates in the UK is one example. Another is that in the United States, the individual states where insurance or Medicaid covers the costs have higher rates. Changes to policy are driven by the results of new research, and moderated by the politics, demographics, and culture of the communities. History. Circumcision is the world's oldest planned surgical procedure, suggested by anatomist and hyperdiffusionist historian Grafton Elliott Smith to be over 15,000 years old, predating recorded history. There is no firm consensus as to how it came to be practiced worldwide. One theory is that it began in one geographic area and spread from there, another is that several different cultural groups began its practice independently. In his 1891 work History of Circumcision, physician Peter Charles Rimondino suggested that it began as a less severe form of emasculating a captured enemy. Penectomy or castration would likely have been fatal, while some form of circumcision would permanently mark the defeated yet leave him alive to serve as a slave. The history of the migration and evolution of the practice of circumcision is followed mainly through the cultures and peoples in two separate regions. In the lands south and east of the Mediterranean, starting with Sudan and Ethiopia, the procedure was practiced by the ancient Egyptians and the Semites, and then by the Jews and Muslims, with whom the practice traveled to and was adopted by the Bantu Africans. In Oceania, circumcision is practiced by the Australian Aborigines and Polynesians. There is also evidence that circumcision was practiced among the Aztec and Mayan civilizations in the Americas, but little detail is available about its history. Middle East, Africa, and Europe. Evidence suggests that circumcision was practiced in the Arabian Peninsula by the 4th millennium BCE, when the Sumerians and the Semites moved into the area that is modern-day Iraq. The earliest historical record of circumcision comes from Egypt, in the form of an image of the circumcision of an adult carved into the tomb of Ankh-Mehaer at Saqqara, dating to about 2400–2300 BCE. Circumcision was done by the Egyptians possibly for hygienic reasons, but also was part of their obsession with purity and was associated with spiritual and intellectual development. No well-accepted theory explains the significance of circumcision to the Egyptians, but it appears to have been endowed with great honor and importance as a rite of passage into adulthood, performed in a public ceremony emphasizing the continuation of family generations and fertility. It may have been a mark of distinction for the elite. The Egyptian Book of the Dead describes the sun god Ra as having circumcised himself. Though secular scholars consider the story to be literary and not historical, circumcision features prominently in the Hebrew Bible. The narrative in Genesis chapter 17 describes the circumcision of Abraham and his relatives and slaves. In the same chapter, Abraham's descendants are commanded to circumcise their sons on the 8th day of life as part of a covenant with God. In addition to proposing that circumcision was taken up by the Israelites purely as a religious mandate, scholars have suggested that Judaism's patriarchs and their followers adopted circumcision to make penile hygiene easier in hot, sandy climates, as a rite of passage into adulthood, or as a form of blood sacrifice. Alexander the Great conquered the Middle East in the 4th century BCE, and in the following centuries ancient Greek cultures and values came to the Middle East. The Greeks abhorred circumcision, making life for circumcised Jews living among the Greeks, and later the Romans, very difficult. Antiochus Epiphanes outlawed circumcision, as did Hadrian, which helped cause the Bar Kokhba revolt. During this period in history, Jewish circumcision called for the removal of only a part of the prepuce, and some Hellenized Jews attempted to look uncircumcised by stretching the extant parts of their foreskins. This was considered by the Jewish leaders to be a serious problem, and during the 2nd century CE they changed the requirements of Jewish circumcision to call for the complete removal of the foreskin, emphasizing the Jewish view of circumcision as intended to be not just the fulfillment of a biblical commandment but also an essential and permanent mark of membership in a people. A narrative in the Christian Gospel of Luke makes a brief mention of the circumcision of Jesus, but the subject of physical circumcision itself is not part of the received teachings of Jesus. Paul the Apostle reinterpreted circumcision as a spiritual concept, arguing the physical one to be no longer necessary. The teaching that physical circumcision was unnecessary for membership in a div.
Please subscribe and thanks for watching.